Welcome to the Science of Sickle Cell webinar provided through a collaboration between the Pennsylvania Medical Home Initiative, a program of the PA chapter of the American Academy of Pediatrics and funded by the PA Department of Health. This webinar aims to address the challenges related to the transition of adolescents and young adults with sickle cell disease, healthcare utilization trends that emphasize the clinical significance around successful transition, and outlining the strategies to improve the transition process for adolescents and young adults with sickle cell disease. I'm a pediatrician at St. Christopher's Hospital for Children and medical director of the Pennsylvania Medical Home Initiative. This webinar is being recorded. The recording will be available on the PA Medical Home Initiative website and will be posted on the University of Pittsburgh Internet-Based Studies in Education and Research ISCR website. For safety purposes, please be advised that Dr. Smith-Whitley discloses that she is part of the Advisory Board for Pfizer, Council for Change, and Advisory Boards Cirrus Novartis, Global Blood Therapeutics, and BioVertibos. Dr. DeJoy Brewer discloses that she is part of the Advisory Board for Pfizer, Council for Change, and is a consultant for SLAY, and I, Renee Turchi, have no disclosures. Please note that the information presented in this webinar is educational in nature and does not necessarily represent the views or policies of the PA Chapter AAP or the funders. Now, allow me to introduce Dr. Kim Smith-Whitley, who is a pediatric hematologist-oncologist and is the director of the Comprehensive Sickle Cell Center at the Children's Hospital of Philadelphia. Her research in sickle cell disease has focused on pulmonary complications, infections, and transfusion-related complications, particularly red cell alloimmunization. Dr. Smith-Whitley obtained her medical degree from the George Washington University School of Medicine and completed her residency in pediatrics at the Children's National Medical Center in Washington, D.C., where she developed an interest in sickle cell disease. She went to CHOP for a pediatric hematology-oncology fellowship, and after completing her fellowship, she remained there to join the faculty in pediatric hematology. In addition to sickle cell research, she is interested in improving access to high-quality care for children and adults with sickle cell disease and has received numerous awards recognizing her expertise in teaching, advocacy, and clinical care, including the Master Clinician Awards at both CHOP and Penn, where she holds the Elias Schwartz Endowed Chair in Hematology. She is a member of the National Institutes of Health, National Heart, Lung, and Blood Advisory Council, and she is the immediate past Chief Medical Officer of the Sickle Cell Disease Association of America, Incorporated. Dr. Margie DeJoy Brewer received her undergraduate with honors degree from Long Island University, CW Post Campus, and a medical degree from University of Pennsylvania Medical School. She then dedicated 2 years to research at Children's Hospital of Philadelphia Sickle Cell Disease Comprehensive Team, the CDTCT, before completing a residency in internal medicine and physical medicine and rehabilitation at Temple University Moss Rehabilitation Hospital. She currently serves as medical director for the Sickle Cell Disease Association of America, Philadelphia Delaware Valley chapter, and also serves as a clinical research outreach liaison for the Hydroxyurea Education and Transition with Sickle Cell Disease Comprehensive Team at CHOP. Her dedication is from her dual role as a clinician and an individual who has sickle cell disease. This gives her a unique perspective on sickle cell disease, frequently making her the go-to person when subject matter experts are needed. Dr. DeJoy Brewer sees her life's mission as bringing awareness, education, and hope to those living with sickle cell disease, as well as their families and caregivers. She views mentoring as an extension of her life's mission and is essential to her goal of educating, advocating, and spreading awareness. She established her health and wellness consulting firm, NAD Fit, in which the services combine medicine, fitness, nutrition, community health, and precision health management to treat patients in a holistic manner. She dedicates herself to making the world a better place by making it healthier, one person at a time. Dr. DeJoy Brewer's research interests include best practice models that enhance the healthcare treatment protocol and quality of life for individuals who suffer from chronic illnesses in general and sickle cell disease in particular, with specific areas of focus including sickle cell disease as a public health initiative, the use of prescribed exercise in the treatment of multiple disease processes, nutrition as medicine, transition from pediatric to adult care, and comprehensive and precision patient-centered health care treatment planning and delivery. We are delighted to have both doctors present on this timely and important topic for primary care clinicians. Thank you both so much for being here with us today. And Dr. Kim Smith-Whitley, please begin your presentation.
Thank you for that introduction, and thank you for the invitation. I'm very excited to be able to speak to you about bridging the gap, improving sickle cell disease transition from pediatric to adult-focused care. I've gone through the disclosures previously. We've gone through those, but I want to give you a good discussion today on challenges related to the transition of adolescents and young adults with sickle cell disease. I would like to describe healthcare utilization trends that emphasize the clinical significance around successful transition and outline strategies to improve the transition process for adolescents and young adults living with sickle cell disease. As an introduction, sickle cell disease is a complex chronic illness in which people with sickle cell disease require comprehensive care across the lifespan. This requires coordinated care that involves patients, families, providers, and health systems, as well as community-based organizations, federal agencies, and private industry. There is a very well thought out pediatric model of chronic care as well as an adult model of chronic care that needs to be centered and expedited through a medical home. And I think that many of us know the challenges of living with a chronic illness, but living with a chronic illness where there are significant health disparities really takes all of these components working together to achieve successful outcomes. Sickle cell disease is an inherited hemoglobinopathy or hemoglobin disorder characterized by hemolysis, vascular occlusion, and unpredictable clinical complications such as acute pain, life-threatening infection, stroke, and acute chest syndrome. Sickle cell disease in the pediatric aspect has transformed from a disease of childhood to a lifelong chronic condition. And we'll talk about that specifically with data from Chuck Quinn that really shows that we are more successful at getting newborns to 20 years of age. And this is related to primarily early diagnosis and initiation of infection prophylaxis, comprehensive care, aggressive management of acute complications, particularly acute chest syndrome and splenic sequestration, and then instituting transfusion therapy for primary and secondary stroke prevention and other neurologic complications. In the old model of thinking about sickle cell disease, this really gives us a nice picture of these nice round red cells that go through small blood vessels fairly easily in this concave disc form. And the understanding that sickle hemoglobin causes changes in the shape of red blood cells and interactions with the blood vessel wall that lead to vascular occlusion. And if that blood vessel is leading to a bone or a muscle, that ischemia that results from that log jamming could result in pain. If it's an area that's supplying the brain, strokes and silent infarction, increased risk for infection because of splenic dysfunction and pneumonia-like illnesses such as acute chest. We know that there is a new model of thinking about sickle cell disease and the underlying pathophysiology that really emerged in the last decade, and a new appreciation of the role of nitric oxide reduction due to chronic hemolysis that leads to then endothelial dysfunction in individuals with sickle cell disease. That concept has really broadened our approach to thinking about the underlying pathophysiology of sickle cell disease. It's not just a disorder of log jamming of red cells, but also understanding the role of white cells, platelets, and the endothelial lining, and that all of these components really play a role in decreasing perfusion to end organs in individuals with sickle cell disease. Other aspects of sickle cell disease, such as an increased risk for thromboses, particularly pulmonary embolism and DVTs, led to further investigation in the role of coagulation, and there have been some agents directed at this as well. Recently, white cells have gotten a lot of attention in sickle cell disease, and there are new agents that are anti-selectins and signaling agents that lead to white cells acting differently in individuals with sickle cell disease. And there are new therapies targeting these white cell, red cell, endothelial wall interactions in order to either lessen the course of an acute painful episode that's ongoing or preventing recurrent episodes. It is now quite impressive what we understand about the underlying pathophysiology of sickle cell disease and how all of these different components actually lead to reperfusion, perfusion injury, abnormalities in repair of tissues, that also play a significant role in the underlying pathophysiology of sickle cell. That said, as we have also started to learn more about the underlying pathophysiology of sickle cell disease and how to design new targeted therapies, we have really applied what we've learned about infection prevention, stroke prevention, acute chest prevention to the pediatric age group. And there's a recent article by Chuck Quinn, actually not so recent anymore, it's a 2004 article, but really demonstrated that individuals born with sickle cell disease now who are diagnosed in the first 2 years of life started on infection prevention therapies such as penicillin twice a day, every day, also survived longer, to 93% making it to 18 years of age, as opposed to the old quote in the 60s that we said 40% making it to 20 years of age. Despite all the advances in infection prevention, stroke prevention, and acute pain prevention in those living with sickle cell disease, we continue to have high morbidity and increased mortality. One of the issues is that there's really no universal cure. Although stem cell transplantation is a cure for individuals with sickle cell disease, you have to have a sibling that does not have the disease and is a perfect HLA match. And that's rare in the sickle cell community. The other issue is that we still have few disease-modifying therapies other than hydroxyurea and now L-glutamine that are directed at not only preventing acute pain, but in decreasing chronic organ damage associated with sickle cell disease. The other issue is a systems issue and a health disparities issue, as our sickle cell population has poor access to high-quality care. And we really need to improve the care that we're providing even further by addressing therapies other than curative therapies to lessen pain, prevent recurrent pain, prevent acute chest syndrome, prevent thrombotic complications and renal disease in individuals living with sickle cell. So what do we know about mortality and the differences in these last 2 decades compared to the 60s and 70s? And it's very clear that when we apply our new therapies in infection prevention and in stroke prevention to the pediatric population, that we really saw an increase in survival in infants with a 61% reduction in mortality in infants, 67% in those in 1 to 2 years of age, and 22 to 35% in children 5 to 19 years of age. However, after 19 years, mortality increased from 0.6 to 1.4 per thousand in the 20 to 24-year-old age group. And this is very distressing when we thought we were doing so well with implementing disease-modifying therapies. Even though there's a tendency towards longer survival, it's really distressing that we're seeing this increase in mortality in the 20 to 24-year-old age group just at the time when they are being transitioned from pediatric to adult-focused care. The other thing that is remaining staggering in individuals with sickle cell disease and in the healthcare system is that the cost of care remains extraordinarily high. For an average individual living with sickle cell disease reaching the age of 45, the total undiscounted healthcare costs were estimated to be $953,000. And the lifetime cost remaining incredibly high, higher than any other chronic illness. So this is a disorder that is not only improving where we have not seen improvement in the quality of care and in the quality of life, but we're also seeing high costs associated with care. The other problem that remains is the stigma associated with sickle cell disease, and this is largely related to the ethnic and racial groups that are impacted by sickle cell disease here in the U.S., primarily people of color, and as well as the stigma associated with acute and chronic pain management. There has been a heightened awareness around opioid use in our community, but it's mainly a heightened awareness around opioid misuse. but not a heightened awareness of the need for certain populations of individuals to continue to use opioid therapy who use them well. And I think that this sickle cell population has really been disserviced by inappropriate application of some of the CDC recommendations around opioid prescribing. The other impact in the community, which has been quite remarkable in the pediatric population, is that providing good care requires many, many resources. And what the expectation for care in the pediatric group is that you would expect to see an individual living with sickle cell disease for outpatient visits 3 to 4 times a year. They, of course, need to have their routine pediatric care 1 to 3 times per year. If you have the SS type of sickle cell disease, and that's 65% of our population, then they need to come in 1 to 2 times per year for radiographic studies, including transcranial Doppler ultrasounds that can predict stroke risk in kids 2 to 16 years of age. If they're at high risk for stroke, there's a 92% reduced incidence of stroke for those that are chronically transfused. Think about the routine immunizations, the dental care. If they are on hydroxyurea therapy, then they need to be seen at least once every 3 to 4 months, sometimes more frequently for dose adjustments here in the hospital. And if they're on chronic transfusion therapy, they have to come in the night before their routine transfusion and the day of transfusion, and that is every 3 to 5 weeks. And that is not accounting for any urgent care for febrile illness and painful episodes. So you can imagine that this is a very complex chronic condition that requires well-coordinated care. 33% of individuals with sickle cell disease have asthma, and so pulmonary cardiology visits for pulmonary hypertension, neurology visits for silent infarcts and stroke, as well as behavioral health, is instrumental for comprehensive care that is best provided in a medical home. So I've really given you the groundwork for why I think a care model for sickle cell disease must include multidisciplinary care, comprehensive care that is accessible and well-coordinated and evidence-based. I think it's not lost on this audience that behavioral health should be integrated and available to this population, and we know how difficult it is to find good behavioral health care in our community. We have to also support academic and vocational goals for individuals living with sickle cell disease so that they can go on to college and jobs when they transition from this program. That's kind of our transition squared model. And then really trying to make it so that care is provided wherever they are. And so trying to provide care for those that are attending colleges is very challenging in the Commonwealth of Pennsylvania if they are not in urban areas for college. This takes a village at my hospital. I'm very lucky to have resources such as sickle cell nurses, program coordinators, social workers, and behavioral health specialists in clinic working with me, as well as a fabulous hydroxyurea educator. We have 3 community health workers that we're trying to implement in our program as well as many physicians and research coordinators who help to make things work. But I think we also have to recognize the unrecognized heroes, and that the general pediatricians that are providing care for our patient population, surgeons, ophthalmologists, pulmonologists also involved in their care, as well as our MINT team that helps us through the transition process. And this really requires care coordination extraordinaire that really has been embedded within our electronic health record in order to make sure that we can track outcomes in this population. So given all that I've stated here, this is really the metric for pediatric resources. What is the answer in the adult world? And I think that this is one of the biggest challenges in transition of individuals living with sickle cell disease is that oftentimes they can, if they are lucky enough to find a sickle cell expert to handle their adult-focused care, they may not have the team around that expert that is really needed, such as social workers, nurse practitioners, and behavioral health specialists, nutrition specialists that come along with that. And we really need to address increasing resources for adult care of patients with sickle cell disease by developing multidisciplinary comprehensive teams. So what does this mean for sickle cell disease? Overall, it means that we have individuals who have been identified at birth with sickle cell disease are in comprehensive care centers and getting good care, and more of them are making it to 20 and 21 years of age, where at our institution we continue the transition process that was begun at about 15 to 16, but really transfer care by age 22. It means that we continue to face very expensive care and barriers to care, particularly where insurance issues are a challenge across the emerging adult population. What is available for an 18-year-old is not always the same degree of availability at 22 years of age. We are dealing with a population that is still continued to be stigmatized by acute pain in our healthcare system. And then we have a pediatric population with increasing outpatient needs for preventive services for preventing pain, preventing acute chest syndrome, and preventing infection and stroke. And again, as I mentioned, the pediatric resources are more likely to be available on our side of the fence than on the adult care side of the fence. So transition, according to the Society for Adolescent Medicine, is a purposeful, planned, and timely movement from child and family-centered pediatric healthcare to patient-centered, adult-oriented healthcare, with the goal of optimizing health and maximizing each young person's ability to attain his or her maximum potential. And what does that look like at a population of patients here in an urban community in Philadelphia? Currently, we care for 1,076 individuals living with sickle cell disease here at CHOP, Maine, Voorhees, and King of Prussia. We have 159 between the ages of 18 to 22. 18 of those come in for routine transfusions and 35 for routine hydroxyurea therapy. And then we have another population here at CHOP, Maine, and these are just CHOP, Maine numbers, of 98 in the ages between 15 and 17 years of age. Despite that, we only have 11 individuals who are hospitalized frequently for pain, classified as high utilizers, and only 2 that live with greater than 50% of their days on opioid therapy. So I think that what I'm trying to present here is a very high-functioning group of young individuals who are not necessarily very savvy with pain because they've been well cared for on hydroxyurea therapy for pain prevention, that are now emerging adults into our working and college population that need to find good adult care resources. Who transitions successfully? Classically, females younger age, non-African Americans, and individuals who are very well resourced, who are cared for in a private, in a medical home, who are privately insured. And that's not the general individual living with sickle cell disease here. We see more of our patients who need services related to long-term therapies because they're on hydroxyurea, they're receiving chronic transfusions, and we know that we have a slowly decreasing percentage of adolescents and young adults who are transitioning from chronic transfusion therapy onto hydroxyurea therapy. Given that, when you look at our 1,046 individuals living with sickle cell disease, of the 770 cared for at CHOP, Maine here, 385 are currently on hydroxyurea therapy, and 85 are receiving chronic transfusion therapy. So this is a population that as they grow up will be on long-term therapies as they go through the transition process. So what are the barriers to transition? One, we just don't have the manpower. We have adult-focused sickle cell experts that are primarily in urban centers, but these individuals are retiring, and we don't have young people coming into their roles willing to take the baton for adult-focused care. We don't have good systems in place, surveillance systems and registries for tracking outcomes. We don't know where individuals with sickle cell disease are living in the Commonwealth of Pennsylvania, and we don't have great tracking systems to see whether or not they transition well. Transition is a process, not an event. It requires a lot of resources and care coordination for many, many years, making sure that you inform that individual about their disease so that they have to have good disease knowledge, they have to have good disease self-management skills, and they have to have knowledge about how to navigate the healthcare system. And so this takes quite a long time, and it's not a one-size-fits-all. It has to be individualized according to not only what the individual's resources are, but also how well they gain these skills and demonstrate this knowledge. We are using here the American Academy of Pediatrics GOT Transition Program. It's really been a process for us because you have to have a very robust transition policy, and you have to make sure that that's been communicated to all. As a pediatrician, I think most of you all know what it's like to have to tell that family for the first time that their child is going to come back to the exam room without them and that they will be joining them later. So you have to get everybody bought in to this concept of transition and having disease self-management go towards that individual, that young adult with sickle cell disease, as opposed to relying on their family. We have to really think about other ways of getting good markers for successful transition. And it's not just that individual that goes to see that adult care provider for the first time. It should be that individual who is seeing that adult care provider 5 years after you transition them. And those are the kinds of tracking systems that we need to have in place for the sickle cell population, and they're just not here yet. I think that for the solutions, and this is me wrapping up this topic and about to pass the baton to Dr. Joshua, I think that one of the things is that we really have to have a systematic approach. We have to have a well-established usual care system, and we have to have community-based resources that really follow that individual living with sickle cell disease across the lifespan. It cannot just be transition from a pediatric care to adult-focused care. It also has to be transition from high school to either a job or high school to college. You have to make sure that the life skills or the life goals for that person are well in place, as well as the medical side of care. And then I think it's really to try to identify healthcare providers, not only that are willing to develop expertise in the care of sickle cell disease, but also those that are willing to provide comprehensive, multidisciplinary, compassionate care. And also being willing to work with not only the community, but also that family. And that's a hard thing for many adult care providers to have the resources to take on. And that's why you need to have a social worker, a nurse practitioner also involved in that practice. I think that we need to better utilize navigators and peer mentors through this process. And then really, again, to make sure that community-based organizations are involved in this process from the beginning to completion. And that completion is not just with the first visit, but is actually following that young adult into adulthood and across the lifespan. I have to advocate always for increased funding for adult-focused sickle cell care. We really have to devise the same metrics clinically that we provided for pediatrics, So making sure that they have access to experts in behavioral health, nutrition, pain management that was present in pediatrics needs to be there in adults as well. Making sure that they have services, specialized services, such as erythrocytophoresis, which can be iron-reducing methods and not necessarily needing chelation in individuals with sickle cell disease, and also good transfusion services with good red cell matching to prevent alloimmunization. Of course, we need better ways of managing chronic pain across multiple different diseases, and sickle cell disease is one that is very much in need of other measures to address chronic pain. And then I think that we need to identify and train additional manpower, both for sickle cell expertise, not only in the pediatric side, but surely in the adult side as well. So in summary, transition is a difficult process in all populations of individuals with chronic illness, but particularly it's challenging in individuals with sickle cell disease, many of them who have comorbidities and are fraught with having few resources for adult-focused care. The programs we have should have a formal transition program, such as the GOT transition program, and we should have many, many adult-focused care programs with options for patients with sickle cell disease, not just one or two in a geographic area. And we need to increase advocacy efforts to improve and increase our resources for adult-focused health care for individuals living with sickle cell disease. And with that, I'd like to turn it over to Dr. Joshua, who's going to talk about transition from her perspective.
Okay. Thank you again for that intro at the beginning, and now I'm going to pick up from where Dr. Kinsfield-Whitley left off, giving that groundwork information and kind of giving us a refreshed look at what sickle cell disease is and how we're redefining the science of sickle cell disease, and the structure of what transition could look like, and if it's a reproduction of kind of what we provide here at Children's Hospital of Pennsylvania or Philadelphia, it would be phenomenal to take that over into the adult world. And when we talk about transition, though the burden of care and the burden of just sickle cell disease as an illness is great, we do speak the mantra of living well with sickle cell. It's a phrase that was coined actually by Dr. Kinsfield-Whitley years ago that I always say and always mention because it's very doable. I think when our patients are taught the right building blocks and given the tools and the ammunition in order to take better care of themselves, and they're aware of what transition is, and that transition is very fluid, and it's an ongoing process. But if we can plug them in the right way, then they are all capable and able of living well with sickle cell. So what does that mean overall? Living well with sickle cell or any chronic illness requires the coordination of many components, which was referred to earlier. A person who has sickle cell disease wants to maximize their life potential. I don't know that anyone doesn't want to, in a way, maximize their life potential. We all have many challenges, and I do think that sickle cell disease in itself is makes that challenge that much more challenging, to use the word twice. But it really requires us to focus on this population and give them a little bit more care in making this transition, because it is a taught skill. It's not something that will just become innate to individuals who have this illness or any chronic illness. The desire to live a quote-unquote good life is universal and the right that we have as human beings, and we really try to communicate that to our patients. There are patients that happen to have sickle cell disease. We don't try to box them into any disability type of category. They are capable and able to achieve any and every goal that they can imagine and dream of. Our population wants to enjoy the gifts of the earth like everyone else, and the diagnosis should not prevent them from living well with sickle cell disease. So a little bit of background, a growing number of teens live with chronic illnesses, and the vast majority aspire to live and work independently. Teens and parents express anxiety, of course, associated with medical and social transitions. I think that goes to, without saying, for any chronic illnesses, especially with our population group. Transition is a time when our sickle cell population experiences increased challenges secondary to their chronic illness. So we find that in this transition model, we're really treating the family and the patient. And it's important we put the patient first at all times, but that has become their support network. We're the affiliate support network, but making sure that everybody can get through this process because they're going to need those family and friends moving forward throughout their lifetime. It's important that everybody's on the same page. So transition for all of them becomes important. Parts of transition to adulthood include being able to explain your illness, as was referred to earlier, communicating medical needs to other healthcare providers, which at many times is easier said than done, especially when you might be going through your challenges or you've experienced things at a different time frame from when you're actually in front of your healthcare providers, making sure that our patients can concisely communicate what their challenges are and then what their needs are in a way that the healthcare provider really can understand them and meet those needs is very, very important because they're left to everyone in kind of understanding and interpreting what they're saying in different ways. So the better that we can arm them with the tools and communicating it very clearly, the better off that they are, and the quicker that they'll get the care that they deserve. Taking responsibility for your own care, including medication, appointments, and all the other things that are included are important. It's a step-by-step, approaching it in a step-by-step way because it can be very overwhelming. I mean, once you leave a comprehensive care center like we have here in CHOP, and then you're thrown or thrusted into the adult world, the responsibility that fall upon you as the primary care person are quite numerous. So making sure that they can approach these in a systematic way is important. Incorporating medical care into daily life. So with a chronic illness, taking care of yourself is what you do every single day. And we really do try to set this type of a basis for our patients so that it's not just acute care or reactive care. It's preventative care, and it's care in making them more healthy in their work environment, in their college environment, in their home environment, so that we'll see that their quality of life just improves overall, and hopefully the acute components of their illness, to the point that we can help control it, become much more stable. Understanding the differences between pediatric and adult-oriented health care is also part of that transition. Wellness is defined as the quality or state of being healthy in body and mind, especially as a result of deliberate effort. And in every model for a chronic illness, it is definitely the deliberate effort of the patient and the individuals surrounding that patient in making them well and better. It's not just going to happen on its own. They really do have to plug into a program, and we try to teach them that while they're here, and then, of course, transition that into the adult world. An approach to healthcare that emphasizes preventing illness and prolonging life as opposed to emphasizing treating or training the disease. So the objectives and measures of living well with sickle cell, I like to just talk about them and what we can decrease and then what we can increase. And again, this changes and is fluid for a lot of the patients, but I think these parameters are steadfast. So we try to decrease the number and length of crises. We try to decrease the number of hospitalization admissions and ER visits, the number of complications that they may suffer, the number of days in pain. What we've always seen is that patients with sickle cell disease do not really report all the days that they're normally in pain. So when you talk about that chronic and acute pain in combination, out of a month, 30 days, a patient can be actually in pain the entire month, but just reporting when they have the most extreme pain. So being able to have them understand what that pain means, what they should be able to push through, quote unquote, or get through, and what pains require some type of treatment and where they should limit their activities, all of that needs to be understood and then taught, navigated, and then adjusted as their body adjusts, because as their illness evolves, the pain syndrome and the other complications will also evolve with that person. So the more plugged in they are, the more astute they are in picking up on those signs early on and managing them in a preventative way, the better that the patient does overall. Days missed at school or work, and decreasing medication needed for pain relief. I'm a big proponent of, if that can decrease all the meds you can take, I really want you to be able to do that and take care of your body in the most natural way possible. But the reality is, when that pain is acute, I also want our patients to be able to take what they need, when they need it, to be effective, and then be off of those medications as soon as possible. So what do we try to increase? What do we try to teach that transition in adult population that they should focus on? Increasing the life expectancy, which we've seen a wonderful increase in the pediatric range, and we want to see the same. I mean, our patients are living into the 80s and 90s now, so the hope is that more and more of them will live into that age, but with a good quality of life. I like to tell the patients to count the good days, and if they can increase the number of good days, again, stay in the positive and the affirmative, then the better their outlook will be. And then, of course, the goal the following month is to have even more good days. The focus sometimes is so intent on when they're not feeling well. Giving them a different perspective helps them look at their illness in a very different way and hopefully address it in a more positive way. Increasing the use of alternative modalities, increasing the ability to reach goals because they are all capable of it. I think it's just putting it into the right format for them. The path of a sickle cell patient will not probably be the traditional path, but their end goals can be reached. So helping them navigate through that and realize that they're still capable and we can take any different combination of way to get there, and that's within their power, I think really does empower the patient. And in empowering them and having a more positive outlook, they do better overall. Increasing their social network, because we do see that patients with sickle cell disease are much more socially isolated. And that social isolation can actually triple the burden of the illness. And it can get very scary. It can be a very challenging and dark place. So the more that we can keep them connected to the resources, be it here at the hospital or others that we've helped them develop in their community or through their families or through individuals that they look up to, the better off that they will do because they'll always have someone to connect with. Self-advocacy, I couldn't say enough about that because they do become at times the patient is the expert in the room. And they then have to be able to self-advocate for themselves even when they're not feeling well. And that also is a skill because the last thing sometimes these patients want to do is speak to someone who's not, quote unquote, getting it when they're not feeling well. But we also realize that if they're not able to advocate well, that becomes a barrier to care. So the better that they can take control of that, the better that we can assist them in that process, the better off they'll be. And lastly, increase the number of significant events that they're able to attend. I always tell patients, think about the last wedding you went to, or if you made it to graduation, or if you made it to prom. Those are the things that put a smile on their face, and being able to be connected with them and help them make more of those events helps them get a different perspective on what their life can be. The true measures, what it boils down to is your glass half full? I'm oversimplifying, but it really does. Is it half full or half empty? We always try to make our patients focus on whatever positives there are in their lives, and there are many. Continuing and celebrating the good days, using events as goals to get better, acknowledging decreased med use, the simplest thing. If you had less pain days or you took one less pill, every single step is an achievement and an accomplishment. And if we celebrate those as they achieve them, then hopefully they'll achieve more. And finding ways to maintain stability at work, in school, and in life. The overall components of living well. Through living well with sickle cell, an individual process. There are some components that our community should be collectively addressing. And some of those include education, self-awareness, knowing your illness, your triggers, and drivers. That's a community, I think, a great community initiative in terms of trying to really help individuals realize the different nuances that may influence how they feel, because an onlooker may see things that they may not. And if they trust the individuals in the community, they'll more readily listen to what they have to say, integrate that knowledge, and then use it in developing preventative measures in taking care of themselves. And one of those preventative measures is really knowing what will take you over the edge and preventing those situations to the best of your ability. Some of them we're not going to be able to prevent, but the more that we can help them control their illness triggers and drivers when it comes to crises and having other problems and complications, the better than they'll do long term. Knowing when you start to become sick and being aggressive in treating at the beginning and not waiting until that paradigm shifts to a point that you need more acute treatment or attention. And teaching individuals to pick up on that early on and plugging to the process earlier is a part of educating them about their illness so that they're not waiting to the last minute. Knowing your, since it's simple things like knowing your baseline hemoglobin, knowing your hospital medication regimen, having an at-home medical plan, and knowing what your cocktail, your particular cocktail is, and being able to speak on these points with clarity and a firmness really helps in receiving better care, having people respect them, and taking ownership of their illness. And we do see that when they're strong in those three areas, they do better long term. So medical transition also involves the parents and caregivers. We want to reinforce the knowledge of sickle cell disease early and often. which we really do that here at this institution. And I think even going further into adult environments, because the illness changes and we're always learning new things, being able to re-educate the family and making sure that they're understanding the process that's going on is a very big part of this illness. As new complications may develop, whether they are or are not connected to their illness is very important. Making sure that they're going to the right providers is very important. Making sure that they know what to look for in their body as it changes is very important. All that requires education of the team that's taking care of that patient, including themselves. Encouraging participation in medical appointments, giving them the support and supporting their voice. So the youth, what we want them to do is to take charge in a sense. Practice talking to doctors alone, because that is an acquired skill. Asking questions. We don't want them to feel intimidated or feel like their voice is not going to be heard. So we want them to ask questions during appointments. We want them to be responsible for taking and filling their medication. We want them to be able to access medical information electronically, because so much information is now electronically delivered, that having them master that so that they can see their own blood work. They can see what tests have been done on them. They can really get a perspective of where their illness is progressing, where they have been, and where they're hopefully going is part of their medical transition. So being able to make sure that they have a firm grasp of that is very important. Providers can help in many ways, and those include identifying adult providers, which we talked about before. Though there is a paucity of them, there are some. So being able to seek out the ones that we feel comfortable connecting our patients to is one of the biggest things that we can help them with. Helping them maintain their health care with someone that is at least knowledgeable of what they're going through, I think is the safety net that they're looking for, and then hopefully they can develop that relationship as they move forward. Formulate a plan of care, which because it changes and it's fluid as they get older, we want to make sure we go over the points. And a plan of care will include 10 different points, 15 different points. So making sure that they're aware of what we're passing on in their file and what they're able to control is very important. Designing an acute care passport is an instrumental component of transition, and we do try to make sure that all our patients here have a care plan in place, have a passport. Some of the adult hospitals actually document what their care plan is, and they've given them a card so that when they present at different facilities, that information is right there on their person. And we do find that that helps tremendously in our young adult population and even adult population, because so many things can change. Promote independence in youth. Explain sickle cell disease in a way that the patient really understands it. And I think waiting until the patient gets that aha moment, when you know and can see that the light bulb goes off for them and their providers, is always what you're chasing and trying to achieve. So it's not good enough to just present the information. You have to engage them in a dialogue to make sure they understand it in the simplest way possible, because the more comfortable they are with the information, the more empowered they will be and proactive they will be when it comes to taking care of themselves and managing their transition, which will go on throughout the rest of their lives, because their care will change as they get older. Emphasize importance and adherence to meds. As a hydroxyurea educator, I'm always going to push hydroxyurea wherever I can, but then I also plug all the other alternative and other mainstay medications like penicillin, folic acid, where it's appropriate, and other things that I will mention in slides to come. Treatment as part of the transition program. The best approach to treatment for sickle cell disease is the biopsychosocial model, which Dr. Kinsford really referred to a little bit earlier. Think about the person as a whole first. So consider the macro factors that may be impacting their disease state, their environment, their stress level, their cultural barriers, their sleep patterns, things that sometimes are not at the top of the list, even the weather outside, but will definitely shift them in one way or another. Are they living in one house or split between two homes? All those things can have an effect on their health, their mindset, and then, of course, in the manifestation of their illness. Then think about them on a micro level, which we're always doing as far as labs go, as far as radiology exams might go, as far as whether they're taking their medication, but it's a combination of the macro and the micro, and as it pertains to their illness. This will help design a true holistic approach to treatment. And knowing the nuances per patient. So going in knowing these are the basic facts to sickle cell disease, this is what I might see the presentation as, but also always keeping in mind that every patient will present a little differently. And if you are able to approach those patients, or when you're able to approach those patients through those type of lenses and looking for those nuances so that nothing is completely just, oh, I've never seen that in another patient, so it can't be happening in you. You're giving them that voice, and you're empowering them to really share the specifics of their illness, and then we're able to be better providers in that way. Because sickle cell disease, as I have learned and as my providers have taught me, can affect every single part of your body. Anywhere that a red blood cell can go, your sickle cell can manifest. And I think the only part that it won't go is probably your earlobe, because it's a bunch of cartilage. So if we think of it in that way, then it can manifest in every part of their body, and then in multiple ways, because it will affect the mind, the body, and the spirit. So keeping that door open to be receptive to everything that they say and give it some type of credence at first, and then help them pull it apart, puts us ahead of a ball for treating them effectively and having them trust us as providers. Consideration when moving away from home. We touched upon this earlier, but I just wanted to reemphasize, is there a provider hospital close by to where that patient is being managed, whether they know sickle cell disease or not? What is your emergency plan? Because sometimes they'll show up in hospitals that may not be familiar. So if, again, they are knowledgeable about their emergency plan, they have a passport on them, they have someone that can be called, it increases the possibility of them getting the proper care and the care that they deserve. How will your chronic illness impact work, school, and other parts of their life? Helping them as a community know what these factors are so that when they go into a job or they go into a school, maybe if they're not disclosing it right away, they at least know what to look for, helps them manage their life better. What pharmacy is near you? Simple things. Does it carry the meds that you need and in the formulary that you need? Because if not, then you need to seek out another location so that you're not stuck at the last minute. And have you found a point person when you're sick? A lot of times I tell our patients and anyone that I come in contact with that it does not have to be a family member, and sometimes a point person who's a little bit more objective and removed is better for you because you're willing to go to them quickly. You know that they'll keep your information private, and they'll get you to the right place when you need it. And that's what we're most concerned about. Are you connected with individuals that can get you to the locations and get you the care that you need when you need it? Because when a patient with sickle cell is not well, many, many times they are unable to get themselves to where they need to be in the time frame that they need. So the last thing we want them thinking about is, where do I turn to next? So if they have that connection, then they can do that. The concept and the model of the medical home is really where the best management of sickle cell disease can be found. It's a patient-centered model, just like the one we have here, and other institutions are trying to adopt. And it takes care of looking at sickle cell and your treatment in a comprehensive way, using coordinated care. Is healthcare and the healthcare system, are they accessible? And we are very committed to the quality and safety of healthcare. Home sweet home. So the other part of the medical home model that I always talk about is the person's home, where they live, where they reside, where they spend the most time. Is that fit to support that individual who has a chronic illness? And many times we'll have individuals who, because they've been at one location for a while, but because they've now transitioned to another home, or they found themselves in a slightly homeless situation, or they transitioned to another state where the temperature is different, all of a sudden their illness takes a different turn. So being able to, again, look at your environment, which I mentioned before as a macro approach to managing your sickle cell disease, is extremely important. Knowing the temperature and being able to have temperature control, medical equipment if you need anything, that it's available, and you have all the supportive things necessary to manage that. Medication storage, cool, dry places, accessible places, shower and tub. So I say that because for a lot of our patients, we do promote using alternative means, and it's not just for relaxation, but even for soaking when it comes to an Epsom salt soak with different oils and so on and so forth. That can be a very therapeutic modality for our patients. So if they have that option, I always tell them to choose that option if they have it. The number of levels, when I say levels, how many floors in the homes, it is accessible by elevator. We've had many patients who, because they're sick, they can't get up to the top floor. And if they live on the 10th floor, then that becomes a problem. It becomes an issue. It becomes a burden of the care of the illness. So do they wait until they're better? Do they have another location that they can go to? Because many times if they live alone and when they're not well, they need someone around. So all these things, thinking about them ahead of time. and other items and issues that may make your home comfortable and medically safe for that person. Overall components in the complementary medicine and nutrition area that I find are very supportive and instrumental, and again, used at different degrees depending on the patient, but all definitely doable, usable. If accessible, we should definitely suggest them for our patients. Some patients rely on acupuncture. Some patients do well with heat therapy. We have a couple of patients who actually do well with pet therapy. We've actually had dogs visit our patients here on the floor, and it completely changes their affect. We have a couple of adult patients who have pets, so they have medical pets, which again brings a calming effect, and actually the pets can pick up on when their body fluctuates and when they're about to go into crisis. It's quite amazing when they have the right connection and when the pet is trained. And this is something that certain insurance companies will actually pay for. Having the right massage therapy, and I tell patients it's not just any massage. There's actually the right therapy to have. So going to a skilled practitioner who knows what kind of therapy can help with circulation, who knows what kind of therapy that can help with bone reformation and also our ligaments, and as we talked about, the adhesion of the blood cells can cause the muscles to stick together. So being able to pull those muscles apart strategically with just the right amount of pressure, because of course for some of our patients, if the pressure is too much, that can also push them over the edge. But knowing the right type of massage and pressure to administer can be a very beneficial thing for our patients. Saunas and soaks, which I mentioned earlier. Topical ointments, there are many topical ointments on the market that can help with localized pain. And sometimes I promote lidocaine patches. So anything that will reduce the oral medication intake, but that will still help them manage the pain and be functional, is what we try to promote. And cupping, which is a modality that I think became more mainstream after the Olympics last year because everybody had the cupping marks on them. But it's an old therapy that's been there for a while and of course has proven to be beneficial for individuals who have chronic pain and chronic illnesses. On the nutrition end, having a supportive, nutritious regimen is what I promote overall for all patients with sickle cell disease. I do think that there are some areas that they can be, that more focus can be placed on. Fluid and water goes without saying, and I usually tell our patients to match their body weight in their fluid intake. Water or fluids with electrolytes like a coconut water or vitamin water are usually the preferences, or diluted real fruit juice is really good for them. Orange juice has proven to have a lot of good effects for inflammation and so on and so forth. Then I tell them if they want to specify their meal plan to look for foods that are anti-inflammatory, antioxidative, immune boosting, and those refer to exactly what we described, Dr. Kim Smith really described earlier in the new model of the science of sickle cell disease. So if you can use your nutritional plan to kind of address all the underlying physiology of how your body would be affected by your illness, then we're putting them, again, 10 steps ahead of the game and really having them treat their illness from within and really just rebuild their body from the inside. Fruits and vegetables, iron if they're low in iron, and addressing anything through vitamins and minerals if their lab work shows a lower level of. Vitamin D is something that a lot of our patients tend to show a lower level of. There's some connection with vitamin D and pain management now, so we're always trying to stay on the cusp of new research, new modalities, and we mentioned L-glutamine earlier also, that could potentially help our patients in any way. Other components to think about are exercise, mind over matter, and support system. Keeping the body moving so that you have the healthiest body possible is very important. I try to tell our patients to keep whatever exercise modality they use, it's one where they keep their heart rate at a lower range but still challenge their body and still build their muscle efficiency. And my analogies I always use is a long-distance runner. So the more efficient that your body can burn, and I use that analogy just for as a body type, the more efficient that they can use the blood source that they have, then the better that they'll do because they have a decreased supply of oxygen. So exercise helps your body metabolism function at a higher level, a better level, and helps your muscle density function at a more efficient level. The ones that we usually promote are yoga, tai chi. We start with those type of exercises. Swimming is wonderful. Cycling, particularly spinning, a spin bike, because you can change the dynamics of a spin bike to match their body proportion. So if you think of someone who has bad hips, a stationary bike is not as adjustable, but a spin bike is much more adjustable, so it will be more comfortable for our patients. Walking is wonderful, and a lot of them love dancing. So we dance at the conventions. We dance at any event that we can. We have one of our nurses that does a dance-a-thon, and a lot of the patients go to it. It's a way that they move and just kind of really make new fresh blood cells and make their body work more efficiently. Meditation, visualization, church and prayer, music, and journaling. I think they all speak for themselves, and they all have a component, a place within a comprehensive approach to treating sickle cell disease. And as far as the support system, we mentioned family, friends, medical staff, other patients with sickle cell disease, community-based organizations, and surprisingly sometimes that stranger who they just make a connection at an event that they go to because they're passionate about sickle cell. That one connection changes their entire perspective. So I tell them never be shy to connect to people and take whatever gifts that they offer. And as a community, we really do have a lot of gifts to offer this population. So when I is replaced by we, even illness becomes wellness. Social stability, networking, advocacy, and connectivity are the 4 other elements of a comprehensive care plan for sickle cell disease that I think are very, very important. And the bottom line, the process of living well with sickle cell is unique to everyone. It requires commitment and dedication, which I think everyone who's participating and listening is all the way in, and all we want to do is bring more people into this network of individuals. It fluctuates and changes as they grow mentally, as their bodies grow, and as their illness changes and progresses, and as our knowledge expands. So if we keep in mind that this is a very fluid process that changes over the decades of life that patients have, there are some very big markers that we can point to, having done so much history and research, that we can look for, but that each individual is so different. Something new always pops up. We see something new every month here and within the community that a patient has developed because of their sickle cell disease. So making sure that we always add to that portfolio and keep our minds open to whatever they might be experiencing, we can really serve this patient population well. So the constant. What remains constant is that in this journey, we have made a decision to not let this illness win. We realize that our patients are worth the time and effort, and that these are the resources that are out that I think are some of the better ones that we use and we reference: Get Connected, SCDAA, and the evidence-based management of sickle cell disease, and ASH, the state of sickle cell, which I love that picture that they used last year. So together as a community, we can really change what transition is and help these individuals live well with sickle cell.
Thank you so much. This concludes our webinar. I want to thank Drs. Kim Smith-Whitley and Dr. Joe Brewer for their excellent presentation. Many thanks to the Pennsylvania Department of Health for the funding that made this sickle cell webinar possible. Thank you so much.